When you're faced with chronic disease, there's a lot of decisions to be made, including how do you take care of yourself, even if it means for a limited amount of time. We're here with Dr. Barry Kinzburnner of VITAS, and really you specialize in helping people make those kinds of decisions, whether they should go into a hospice, which is essentially a place where you live out the rest of your days when you're ill?
Not necessarily a place.
Hospice
is a comprehensive program of services that are provided to patients who are nearing the end of life wherever the patient lives. So in other words, the patient's living at home, we can provide services in the patient's home. If the patient is living in a facility such as a nursing home or an adult living facility, we can provide the care in the facility. If the patient needs inpatient care, we can provide the care either in a hospital, under a contract type of arrangement. We often have space rented in a hospital and have a hospice unit designated within a hospital facility. Some hospices will have freestanding buildings that people go to for inpatient care, but it's generally, hospice care here in the United States is generally provided wherever the patient lives. We bring the care to the patient. What happens sometimes is people struggle with accepting the idea that their illness is life-limiting. And you really need to approach patients earlier on in the course of the illness to begin the conversation so that we can then allow an easier transition to hospice when the time is appropriate. We still find, even though about 40% of people who die on a hospice today, many of them are still dying on a hospice after only a very short period of time. The median length of stay in a hospice is under 3 weeks. So that we'd like to see patients receive hospice services earlier. There are many barriers to that. Those barriers take on many forms, some of which relate to people's preferences around their culture, their religion, or other factors. And as we learn more about these barriers, we've learned different ways to help overcome those barriers to at least begin the conversation sooner. One of the ways we do that is through providing services before hospice is appropriate in the form of palliative care. Palliative care is basically primarily a physician consult service that can again be provided either in a hospital setting or in a patient's home or even in an outpatient office setting if the patient can get there. The physician care is supplemented with other members of an interdisciplinary team, just as we do in hospice. So you'll have nurses, or in the case of palliative care, often nurse practitioners assisting the physician, as well as social workers and chaplains to provide the very important psychosocial and spiritual care that patients need as they're trying to deal with facing a life-limiting illness and the consequences of that. The palliative care services are designed to allow patients to begin advanced care planning and think about goals of care without the pressure necessarily of having to make an immediate decision about issues. So oftentimes patients are seen before they're really ready for hospice services, which usually is in the last few months of life, so that they can begin to think about questions such as, well, if things don't go well, what would you like us to do?
Okay.
What would you like done for you? Do you still want, I hate to use the word aggressive measures, but you still want measures directed at trying to treat your illness, even if the chances of that treatment helping are small? Or would you rather us then change the focus to more focus directed at your symptoms and at making you feel better and supporting you and more comfortable and helping your family and you cope with what's happening?
And what do people normally choose?
It varies. It varies, and again, some of these decisions are motivated not only by individual personal wishes, but by one's ethnic background or one's religious background and belief system. Often dictates how people make those choices.
Well, we're certainly seeing with an aging population that there is the market to really come up with different options. What is the next thing coming up in this area that wasn't around before?
Well, I think the palliative care is the next thing. If you think about hospice, is established now for over It was 1982 when the benefit was actually passed, so we're coming upon almost the 30th anniversary since the benefit was passed. Palliative care is now another way to reach people earlier in the course of illness.
Okay.
And I think it's very, very important because we're really getting to a place where we're helping people think about these things sooner. I think also as healthcare reforms, there's going to be more desire for primary providers to want to have these services, because as we think about, we look at some of the initiatives in the healthcare reform around what they describe as patient-centered care and things of that nature. This is patient-centered care. This is care revolved around what are the patient's wishes and desires in the face of chronic and often life-limiting illness. So I think the option of palliative care a year, even 2 years before the end of an illness, shall we say, is very, very important. And with hospice, we can only reach people in the last several months. And that itself is a barrier to access.
Okay. Well, Dr. Kinzburnner, this is really important information. Thank you for your time today.
You're welcome.
Thank you. I'm Mabel Jong. Thanks for watching.